to look into. And what quickly comes into my mind is the leadership, which really brings in commitment. And we have actually seen that type of commitment, as my colleague did mention, in terms of the government increasing the pot for the first time, actually, providing funding for HIV, TB, and malaria. We have also seen with the counties where we have actually had increased allocation to health, with several counties actually putting in as much as 40%. In terms of the health budget. So Kirinyaga, for example, 40% of its budget is actually on health. Tharaka Nithi is about 38%. Muranga, is about 37%. So we actually see this commitment, and their objective is actually to have the counties allocate, at least up to about 30%. So that is leadership, and it really brings in the issues of prioritization. Now, we also have cases where we actually look internally in terms of what is feasible. Now, at the moment, I would say we do have a challenge in the macro fiscal space. And with this pandemic, we know it has actually led to reallocation of resources, to be able to fight the pandemic. We know we did make projections on about 6% of economic growth. Last year, the economic growth was 0.3%. So it's really going to be a challenge to be able to realize those objectives. If we project on 6% and we are from 0.3%, so moving from 0.3% to 6% is really going to be a challenge. So there's the issue about the macro fiscal space, which brings the next question that, can we best utilize the resources that we have? So to me, that's actually mobilization of resources. The inefficiency, Kenya's health sector inefficiency stands at about 30%, which really means that out of every 10 shillings that we have, we can actually be able to work on the 3, so that we can actually work on that area. And there are several strategies that we can actually use to be able to enhance the efficiency levels.
Okay. And Doctor, the main thing that people are wondering, Dr. Ngugi, is that persons living with HIV and AIDS who are watching now, is their future guaranteed in terms of medication and the ARVs? Is it guaranteed, or are we still on a limbo where we're still trying to figure out whether we can do this on our own? If somebody pulls off, are we going to be in trouble? Is their future guaranteed?
Thank you, Trevor. Yes, it's guaranteed that in the next going forward, that the government is going to take charge in ensuring that the medication is bought by the government. More so, I know you start story by story, because as well, if the cost of medication alone is almost around 16 billion for HIV alone, not adding on TB and malaria. And so that right now, with the 9.7 that have been put in, and knowing, like, for example, out of the 1.2 million clients who are on treatment, 1 million of them, they take a certain drug, that's just one drug, which the engagement with for example, the company that you have engaged in the country, we are assured that being produced in the country, then our clients will not miss. And for the last couple of decades, clients have not missed medication, even right now with what is happening. It's just that they're missing the multi-month dispensing that they used to take around 3 months of the drugs home, but they are not able to take that. But the government, through the Ministry of Health leadership, that we have been able to, we are resolving on the matter. We are almost at the end of concluding. And within the next 1 month, clients will be able to take that medication. Last year, remember, in 2020, when one of the drugs that they take daily, cotrimoxazole, the donors withdrew on it, the government came in, put in 1.2 billion, engaged a local manufacturer, and they are assured of it, that And I can assure all clients that they will not miss the medication because the government, as you saw on Friday, have been able to put in funds not only to procure HIV, but TB, but as well as malaria drugs.
Yeah.
But I know as well that as we go along that we need to put in more money. Look at other countries, for example, Botswana, South Africa, 100% of the drugs are being bought by the government. And that is where we're going self-reliance to ensure as well as sustainability.
Yeah.
And that assurance, because we know HIV, for example, has not only a negative social, but as well as economic impact. But this is a part that we are calling on, especially to the private sector. Because where we are right now, we may not be able to achieve, be able to fight HIV response alone. That's why public-private partnership is key. So is that part of social responsibility corporate? How do we join in together and ensure all of us be able to fight this? Because not only is it affecting the clients, maybe at the individual level, but as well as economically to the country, and they're contributing to the GDP. But even the local manufacturers, imagine having a company that is producing 1 million tablets per day. So imagine how many jobs will be created, but by ensuring that those drugs are being made in the country.
Yes. Engineer, what is the role of the private sector in all this? And opening the floodgates for that, would it be an advantage, or will it just open the floodgates for exploitation of an already vulnerable population?
No, I think gone are the days that the private sector will really come in and exploit the country. Regulations have to be in place properly before this happens. But when you talk about a public-private partnership, especially in the health area, because talking about HIV and AIDS is a bigger component, what private sector organizations look at if they're going to invest in healthcare is what return are they going to get from that investment as a company. And if there is a program that is designed that is going to give them a good return on that investment, then they'll be able to put money into it. Look at how much money private sector companies spend on health insurance, or even just individuals spend on health insurance, right? Now, health insurance is on the, is hoping that, if you get sick, you'll get treated. But if we could spend even 10, 15, 20% of that on prevention, then the burden of treatment will be reduced. And that is really where, if you design prevention interventions that the private sector can then buy into, which then reduces the burden of paying for treatment, I think that kind of design, together with the experts, which is the experts in terms of public health across the whole country, and we can then say a private sector company can put in so much for its employees and then add, say, another equivalent amount for the community where they're working. So, but they need to be able to see where that is going to give a return to the business. Private sector companies will be socially responsible, and their social responsibility is if they can see a situation whereby they can help the community around where they're working in a sustainable manner. So I think the key thing here is to work together with the public health institutions, design a proper program, and make sure that I can see the benefits from it as a private sector organization. Then you get, say, all the companies in Kisumu to sort of subscribe to a system that has been designed by that government, or the county government in Kakamega, or wherever it is, right? And if we have a model that works in one county, it can then be spread across the whole country. And that way it will reduce the burden on the government in terms of prevention. I think for me, the private sector will invest a lot in prevention, because that is sustainable. But if you invest on treatment, that means you've failed at the beginning, and treatment is not sustainable because that will just grow.
Dr. Wina, how can counties play a more active role despite all the issues they're facing now, the issues of financing? In fact, they say they're shutting down on the 24th. But what can they do, all factors held constant, to play a more active role in the fight against HIV and AIDS?
Yeah, thank you very much, Trevor. There are several things that can actually be done, and I would just like to touch on what you have just mentioned in terms of the resources. Now, I think one of the things that the counties need, I think, is a more enabling environment, and one of them is actually aligning, making sure that the planning and budgeting cycle is actually synchronized. And this is something that the counties cannot actually do by themselves. And that really needs cooperation between the two levels of government. And in this case, I know there's been discussions, in terms of the late disbursement of the funds. And in this case, up to about 3 months now.
Yeah.
And what we're actually seeing here is that when the money now comes, it's actually not planned for. And before you even realize, the next fiscal year has actually gone. So in this case, what is critical is if the counties can actually, if you can have, timely disbursement of this fund, then this actually even makes the counties, to be, very, 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 very efficient in terms of provision of the services. Now, the other thing, of course, we know this affects, like the payment of salaries, the statutory deductions. It also affects payment for salaries, which is really a challenge. And where there's a lot of effect is actually in terms of the development projects. Because if you are given now 200 million shillings and, you have to construct, spend, and in the next 2 to 3 weeks, it's really a challenge.
Yeah.
So the other thing that we may also need to look into, which is also a contribution, is we need to ask ourselves the question is, what are we actually buying with these monies? And I look at this as akin to, you do have a lemon, you have cut it, and you want to squeeze as much juice as you can.
You can, yeah.
So which really means that if we look at the health budget, what we find is that about 60 to 65% goes to labor. Now, this leaves about 35 to 40% to be able to buy commodities, infrastructure, and all that. And even within the human resource itself, you actually find that about 54% would also be lost in terms of productivity, will also be lost in terms of downtime. And these are actually areas that we can actually look into so that we are able to make much more efficient use of the little money that we have. And what happens here is we now need to start thinking about shifting towards the result-based financing. You do this, I give this to you.
Yeah.
Instead of approaching it from the input-based, where we say, okay, fine, we're going to buy commodities, we're going to buy labor, we are going to buy all this. So I think that is something that, like the counties themselves, will really be very, very proactive, in terms of moving in that direction.
Yeah.
Now, at the same time, what we actually see, the wage bill, in my sense, is becoming unsustainable.
Yeah.
And especially with the push by the unions. So something really needs to happen, and that's when we actually now need to start thinking of a shift away from the traditional permanent and pensionable towards more contracting, especially starting with the more expensive labor.
Yeah.
Now, this would really yield us substantial gains. And then comes the issue about putting money where we have the biggest impact. And my colleague here, Patrick, and they did mention about really doing something with an impact. And what I have in mind here is that if we look at the way we are currently structured, is we do spend a lot of money on the curative aspect, which really pushes the country towards a disease orientation instead of actually being health orientation as envisaged, in the universal health coverage. So as counties, we are really waiting for the operationalization of the primary healthcare networks, which really have an emphasis on the lower levels, so that any referrals that goes to the upper levels are efficient, and a lot of attention should also be paid in terms of equipping these specific facilities.
Okay.
So as counties, there's also a lot of effort in terms of own source revenue, so that we are actually able to support some of these things on our own.
Yeah.
And one of them is actually Facility Improvement Fund, which is actually FIF, trying to generate resources.
Yeah.
And the counties are actually now working on a model law, which can actually be used by the counties also to be able to protect these monies.
Yeah.
We have had very good examples of counties that have been able to what you call ring fence or protect those funds.
Yeah.
So that's also yet another initiative that is actually being taken into account.
Okay. Okay, Dr. Ngugi, the issue of prevention versus treatment. What is the latest strategy to ensure that we are focusing more on prevention rather than treatment? Because I meet a lot of young people, and you know what they say, that when the campaign against HIV started, they were deterred from it because they could see a really skinny person and they'd say HIV kills. After that, the stigma came when ARVs kicked in. Now people are more scared of pregnancy rather than contracting HIV. What is the latest strategy to change this narrative and this conversation?
Thank you. I think first, when you look at HIV, and you look at both prevention and treatment is still part of prevention. Let me explain why. We have around 1.5 people living with HIV. If we don't put them on treatment, they will not be able to virally suppress. That means that they will be able now still to continue spreading the virus. So you need to put them on treatment to ensure that they can be able to suppress. Now, yes, I agree that in prevention, more so, health education, and ensuring that you use other innovations, for example, using self-test kits so as they can know their status and be put on treatment, as well as use of, ABC, abstaining, be faithful, use of condoms.
Yeah.
But with the data that you have, stated before when we started the program, having almost 62% of the new HIV infections among our adolescents and young persons. There is need for us to change the tactic, because we have realized lately that the intervention, the strategies that we have been using, they're really not working with the adolescents and young persons.
Yeah.
They will tell you, abstain, be faithful, give us other innovations. But then we have another we need, first of all, to bring them on the table and ask them, what is it working?
Yeah.
Now, beyond now that being faithful and use of condoms, we have other innovations, for example, PrEP, that is a pre-exposure prophylaxis.
Yeah.
For the ones who are in risky situations or relationships that they feel that they are predisposed to acquiring HIV, that they can be able to take. But I think the most one that we are not, I think we somehow have lagged behind on it is health education.
Yeah.
What is HIV? How do you acquire it? How can you prevent maybe a pregnant or a breastfeeding mother to ensure that they do not transmit the virus to the young one? But as well as for the couples who are in discordant couples, that one partner who is positive and another one who is negative. That to ensure that, how do you ensure that you're on treatment and you're virally suppressed and you do not transmit the virus? So I think it's multifactorial. We cannot really disengage HIV treatment from HIV prevention. It's part of it, but as well as we have means that and innovations and strategies that have worked to ensure that we can reduce. If we compare since almost a decade ago and up to now, we have reduced more than 65% of the new HIV infections. That means the innovations and the strategies that we are utilizing as a country are working. But we are not yet there, because the 32,000 that you have just mentioned, we can reduce it to almost 10,000 if we are able, all of us, to put all our sectors together. And realizing that government cannot be able to attain it alone. We need definitely the other sectors, health sectors, and as well being the civil society organizations, people living with HIV, to be able to champion that. So as all of us, when you sit at the table, then you're able to see this is the population, this is the cohort that we're having new HIV infections. Which interventions or strategies do we put on board to ensure that we can reduce these new infections?
Okay.
But knowing and and I hear you, sir, but we need as well to have treatment there so as we can be able to reduce. Right now, the mother-to-child transmission of HIV, that is around 11% in the country, yet in around 2017, it was around 5%. We were almost there, but then somewhere around 2017, 2018, we lost a bit of sleep on the interventions that we are putting on board. And this time we have realized that we have saturated the interventions within the health facilities, that we need to go to the community. So integration of services using the community health workers, community health volunteers, to ensure that when they go to those homes and they're talking about malaria, they're talking about TB, they're talking about water, sanitation, that as well they can be able to discuss issues to do with HIV, so as we can be able to reduce mother-to-child transmission of HIV. And when we close that tap, then within the next 5 years, then 3 for 5 years, then we'll have reduced not only new HIV infections and be able then to maintain the 1.2 million that we have, and ensure that even them they're able to virally suppress and be able to thrive without being limited by the HIV status that they have.
All right, I have to take a quick break on that note. When I come back, I see a lot of your feedback and your questions here online. I will post some of them to my guests in just a bit. Keep them coming. At Trevor Mbija to Citizen TV Kenya. Use the hashtag Monday Report. We're back in just a bit.